Good morning. My name is Joshua Sharfstein. I am the Associate Dean for Public Health Practice and Training here at the Johns Hopkins Bloomberg School of Public Health. It's my great pleasure to be here to introduce this live webcast that includes Congressman Henry Waxman, our Centennial Policy Scholar, and Karen Davis, Professor Karen Davis, as they talk about the topic of Medicare at 50. Before we turn to the topic, I'd like to give a little bit of background on the Centennial Policy Series and introduce Congressman Waxman and Professor Davis. The Centennial Policy Scholar and Series is brought to you by the Department of Health Policy and Management. And we were able, and you can see what great fortune it was for us to recruit Congressman Waxman to serve as a Centennial Policy Scholar this year. That means that this year he will be teaching, meeting with students and faculty, engaged with the school on a whole number of health policy issues. Congressman Henry Waxman is arguably the most prolific and important health policy legislator of the last century. He served 40 years in the U.S. House of Representatives, just ending at the end of last year. He authored the Ryan White Care Act for HIV/AIDS, the Hatch-Waxman Act on generic drugs, establishing generic drugs, multiple expansions of the Medicaid program, major improvements to the Clean Air Act and the Clean Water Act, and the Affordable Care Act, among many other pieces of legislation. He was also pivotal to changing the nation's perception of tobacco through the oversight that he did in his work on the investigative committees of Congress. I had the incredible privilege personally of working for Congressman Waxman for 4 years and learning a tremendous amount. And I can tell you it is amazing to meet someone who is both so fearless and courageous in his work and also so kind and supportive to the people who work for him. It is really fabulous for the school that he's here, and I look forward to his comments today. Let me mention that after today, there will be a series of other health policy topics and seminars that Congressman Waxman will be participating in, including on September 10th. The topic is Caring for an Aging America. On October 21st, the topic will be moving mental health and addiction into the mainstream of healthcare. On November 18th, we'll be talking about HIV, and there will be one on tobacco policy in December that will really be fantastic. You can get all this information by going to the School Public Health website and looking under News and Events under the Department of Health Policy and Management. So today the topic is going to be Medicare at 50. This month is the 50th birthday of the Medicare program. There is perhaps nobody who understands Medicare better or has written more persuasively and creatively about Medicare than Professor Karen Davis here at the school. Professor Davis is the Eugene and Mildred Lipitz Professor in the Department of Health Policy and Management and the Director of the Roger C. Lipitz Center for Integrated Healthcare here at the Johns Hopkins Bloomberg School of Public Health. Previously, she served as the President of the Commonwealth Fund, the Chair of the Department of Health Policy and Management, and as Deputy Assistant Secretary for Health Policy at the Department of Health and Human Services in Washington. She recently authored and oversaw the development of several critical papers about the history of Medicare and its future for the Commonwealth Fund, which you can find on the Commonwealth Fund's website. Professor Davis?
Thank you. It is a great pleasure to be here on the 50th anniversary of Medicare and to have the opportunity to look back at how significant this program has been and its achievements over the last 50 years. Certainly what we know from research that Dr. Sharfstein has mentioned is that Medicare has succeeded as a health insurance program for the elderly and disabled. It's reduced the uninsured rate from 48% before Medicare was enacted to 2% today. It's contributed to an increase in life expectancy at age 65 of 5 years, and it has, by all of the surveys that have been done an excellent job of ensuring access to care and reducing financial burdens on elderly people and their families as they seek medical care. Today, we're going to reflect on these achievements, but also look at the challenges. Many people would say that Medicare and Medicaid, perhaps the most significant, along with the Civil Rights Act, significant legislation in the 20th century. I'd like your view of how important you think this program has been.
I think that's a good statement, that they are, along with the Civil Rights Law and Social Security, the most significant laws in the 20th century for this country. It sought to bring justice to all people. And in fact, I think the civil rights time and the adoption of Medicare were similar points of the moment when this country recognizes we needed to be more equitable. It brought about immediately the desegregation in hospitals that in the past had operated under the old segregation rules. And it was a recognition of the equality of people who needed medical care to be able to get that care. They deserved it because they are people. They're human, and they should be able to get it. Access to the doctors and the hospitals and the medical miracles that we had then and we're seeing even more of today. Medicaid is considered an entitlement program, but it's not as fully an entitlement program in light of a recent Supreme Court decision where the Supreme Court on 5-4 said that people could not sue to enforce their rights, which meant that if you were denied access to care, you could sue. If you're a provider and wanted to provide care and you weren't allowed to, you could sue. But the Supreme Court now said the Medicaid program has to be enforced in a different way by appealing to the government to decide, not the courts to decide. But people understand Medicare and Medicaid go together. At one time they were thought of as separate and unequal programs, that Medicaid was an afterthought. Well, it started as an afterthought in 1965 as something just to help the poor who are on welfare. That's not what it is today. It is a mainstream health insurance, as much a part of our whole system as employer-sponsored health insurance or Medicare or the private policies that people can buy on the exchange. It's an integral part of the system and serves a unique population, and so both of these programs are what keeps America living up to our values that everybody should be able to get health care.
Yeah. I think many of the people in our audience maybe don't know a time without Medicare and Medicaid.
That's true.
And it's hard to envision what America and the healthcare system would be like without Medicare. Can you talk about what you think the major changes are that have happened
the thing
as a
we
result?
knew prior to Medicare is that the fastest group growing in poverty were seniors. Because after World War II, people got health insurance through their jobs, partly because employers couldn't give higher wages to their employees. There were controls on that. So employers said, well, I can buy them health insurance and deduct it. So that's what they did. And most people had their health insurance. In fact, today most people have their health insurance through their jobs. But when seniors would retire, they lost their health insurance. And when they had the huge medical bills, because seniors do use the healthcare system because of the aging illnesses, when they used the healthcare system, they couldn't afford it, and many were driven into poverty. That was the primary driver of the Medicare program, and it was adopted on the basis of the Social Security as an entitlement program. You paid into it when you were working. You were entitled to the benefits when you retired, and people thought they paid for it all. Of course, they didn't pay for all of Social Security benefits they got, and they didn't pay for all the health care costs that they were able to receive under Medicare, but they felt the assurance of Medicare to be there in their retirement years. And then, of course, later it was used for people who were disabled. You had to be disabled for, I think, a two-year period.
Mm-hmm.
Not just, and then you're able to get on Medicare even if you're not quite 65. But it is a safety net and entitlement, and has made a huge difference in the lives of Americans.
Yeah, I think you're right to stress how important Medicaid has been as a complement to Medicare. Obviously, they're structured in different ways, as you say. Medicare being a federal program for people age 65 and over, those permanently and totally disabled for 2 years or more. Medicaid being a federal state program with matching support from the federal government, but run essentially by the states under broad guidelines. And it has historically covered low-income mothers and children and elderly and disabled, and then with the Affordable Care Act moving to cover all low-income people. But I'd like to focus specifically on the role of Medicaid in supplementing Medicare for low-income, elderly, and disabled. Many people don't know Medicare doesn't cover nursing home care. So I'd like your views on the importance of Medicaid as a supplement to
Well, a lot of
Medicare.
people think that they're protected from all medical costs when they're 65 and older. And of course, it's not true. There's some out-of-pocket costs that they have to bear. But the biggest costs that seniors have to contemplate as possible are the long-term care costs. And they are not considered medical, more custodial. So if a person became frail and unable to do some of the activities of daily living and had to go to a nursing home, they'd have to pay for it eventually. But Medicare would cover it after a hospital stay for a short period of time. But if they needed long-term custodial care, they'd have to go on the poverty program of Medicaid to pay for that. And so that has been one area where we never thought through the system that we would force people to impoverish themselves in order to get help for long-term care. It should have been another social insurance system, and someday still may be. But Medicaid also became an important part of the Medicare system and for those elderly who were poor and couldn't afford to pay their premiums and out-of-pocket costs. Medicare, even when you choose Part B, you automatically get Part A, but when you choose Part B, there are out-of-pocket costs. Well, even for hospital side, services are out-of-pocket costs. Most people would buy a supplemental insurance policy. A lot of low-income people couldn't afford it. And what we did over the years was provided for the Medicaid program to pay for those out-of-pocket costs. We had programs, I don't even know if they're called this anymore, but Quimby and Slimby.
Surely.
And I can't remember what they stood
Yes,
for.
but you provided the leadership in making that happen.
We were able to do that over the years by saying Medicare is not there for everybody if they can't afford those out-of-pocket costs, and so why don't we use some of the Medicaid money? Usually we were able to get the money for Medicaid by cutting back on some of the provider spending on Medicare prospectively, and then put some of that funding into helping low-income seniors to be able to be a full participant in the Medicare program.
And of course, it reduced bad debts or uncompensated
Yes.
care from those providers. So
Right.
it was a good investment
It was
for
a
them
good
as well.
investment, absolutely.
We'll have to have you come back on September 10th to talk more about Medicaid and
Yeah,
long-term
plan to be
care.
here.
But I wanted to ask you, we all know that
Mm-hmm.
Medicare is a health insurance program, so its basic job is to help the elderly and disabled get health care.
Mm-hmm.
But it's also provided payments to teaching hospitals.
Mm-hmm.
It's provided payment to hospitals that have a disproportionate number of uninsured and low-income people. It's set quality standards. It actually reports now on hospital mortality rates, so you can go on the internet and check that out. How would you talk about the impact of Medicare on the whole healthcare system, broader than just health insurance for people?
And Professor Davis, before Congressman Waxman answers, I just wanted to let everybody know that we'll be taking questions for the second half of the discussion, and people can email questions to publichealthpractice@jhu.edu. That's publichealthpractice@jhu.edu. That's why I have this computer here. Anyway, go ahead.
Good. Well, when Medicare was first adopted, it was adopted because the costs that people feared the most were the hospital costs. And so people wanted to be protected from the very high hospital costs, and Medicare Part A served that purpose. And then they decided to do at the same time what's called Medicare Part B, which pays for physicians and other what they call ancillary services. And I think they believed they were not going to change the practice of medicine. They were just going to cover the costs of
Right.
the health care that will be provided for these people. But Medicare's changed dramatically over the years because Medicare, as you point out, is used to help the teaching hospitals. It would be a higher cost for the role of a teaching hospital, which is training medical professionals, doing some research, providing tertiary care, very specialized and very expensive care. And so we provided an extra reimbursement for the teaching hospitals because they're not just providing the care, but they serve a very important purpose for the healthcare system. Medicare in the Affordable Care Act is going to carry on the role it's played in a much more dramatic fashion of changing the way healthcare is delivered. Originally, Medicare was only a fee-for-service system. Later, we said, you can join a managed care plan and get a certain amount of money and go into the managed care plan. And we decided how much those managed care plans would be paid. But as we adopted the Affordable Care Act, we said, wait a second, still, even with managed care, we're just paying for services. How do we pay more for the quality of care rather than the quantity of care? And so the standards that Medicare set over the years on how to pay, through experiments like diagnostic-related groupings in hospitals, rather than break everything down to another fee, they said, let's put these things together and pay a fee for it, or let's pay a fee and encourage people to use that money wisely. That process is going to move rapidly forward under the Medicare program, under the changes of the ACA, and will be a model, as it has been in the past, for private insurance companies, and a way to learn how to change the whole practice of medicine, whether you're covered by employer coverage or Medicare or an individual policy, even Medicaid. So we're trying to use these systems, try new things out, and people talk about the Affordable Care Act being the great accomplishment. It is, but it's the beginning of what is going to happen in the future, and Medicare will play a very key role in that.
Well, I think that's right. We've talked about hospital and physician services, but prescription drugs were not part of Medicare to start with, and were actually fairly late being added in 2003 in the Medicare Modernization Act. Why was it so slow in coming?
I think in the beginning people thought drugs don't cost much. You can just pay for it out of pocket. The hospitals were the charges they worried the most about, but they said physicians ought to be covered as well and other services. And drugs started to get more and more expensive. In the 80s, we adopted the Hatch-Waxman Act, which provided for generic drugs to be able to go on the market and compete at lower prices. It was very successful. But somewhere around the 90s, drug costs were going up quite rapidly. And it was difficult for seniors who used a lot of drugs to pay for them. They had to pay for them out of pocket. There was no coverage under Medicare. So many of us argued we ought to make it a Medicare service and have Medicare cover it. Just as an aside, we were in the minority in the Congress at the time, and I was the ranking member of the Oversight and Investigations Committee. And we decided we'll do some things on our own, and one of the things we did was provided reports for our colleagues. We made it available to anybody, but Democrats were the only ones who wanted them, that could be issued in the community to show that people in each congressional district were by and large paying twice as much for their drugs out of pocket than people were being charged when they had coverage under their private insurance policies. And we even went to show the contrast between the cost of drugs right here in this town with what people were paying in Canada or in Europe. It was a fraction. They were paying a fraction of what people here were paying. And there was a lot of movement that we should go to Canada to buy drugs because the costs were so high. It was a more from the ground roots up. People were saying, that's right, I am paying too much for drugs. It's unfair that I'm paying too much for drugs. Government's got to do something about it. President Clinton tried to add it as a Medicare benefit, but under President George W. Bush, the Republicans decided, I think quite surprisingly, but I think to a great extent because they knew the politics of it, that they'll provide a pharmaceutical benefit under Medicare, but they didn't want to offend the pharmaceutical manufacturers. So they wrote in the law that the government could not negotiate
Wow.
with the manufacturers of these drugs, even though they were bringing in millions of people to buy these drugs. They certainly should have gotten a discount for the large population that were now going to be able to get drugs. And the Republicans, at the behest of the drug companies, said no negotiations would be allowed. And then the other thing the Republicans decided is we shouldn't just make it a benefit under Medicare. We should make people have to go buy private insurance, a private insurance plan to supplement Medicare that would cover prescription drugs. And if they were in a managed care plan, they could cover it that way. Otherwise, if they stayed in fee-for-service Medicare, they had to go buy a private insurance plan to pay for the drugs. Now, some people said what a great plan this has been. Of course, people love it because they now get payment for their drugs, at least most of the costs of the drugs. But it is a far more expensive plan than we should have adopted. And the other thing to point out is Republicans adopted it, I think it was $400 billion, and they didn't pay for it. It all came out of the deficit. They didn't feel they had to pay for it. When we adopted the Affordable Care Act, everything had to be paid for. We had to show we're going to make cuts and raise certain taxes so that would be cost neutral. But we went into the whole, under President George W. Bush, $400 billion for that, billions, hundreds of billions of dollars more for tax cuts that were not paid for. President Bush inherited a balanced budget, but by the time he left, we had the largest deficits we've ever had, and it was up to other presidents to try to deal with that problem.
I think it was a $5 trillion surplus that President Bush inherited, and that went away with tax
Very
cuts.
quickly.
But as you said, other countries negotiate pharmaceutical prices on behalf of everyone in the country, and as a result, their prices for brand name drugs are often half what we pay in the U.S. from the same manufacturers. Why politically has it been so hard to move forward with negotiation of pharmaceutical prices?
Well, there's a very simple answer: the political strength of PhRMA, the trade association for the pharmaceutical manufacturers. They're extremely powerful. They have a case to make that they do such a great job in providing the miracles for the future. And they argue that whatever money they make goes into research and investment for new breakthrough drugs. And there's truth to that. But they spend more money on marketing in a broad sense, their products, than they ever do on research. And a lot of them didn't do the research. They bought a company that did the research and produced a product, and then they buy that company and then market the product at a much higher amount. So they're very powerful, and they've been able to keep the government, even under the Affordable Care Act, from making sure that we could hold some of those drug costs in check. They were one of the big winners in the ACA. The Obama administration decided they didn't want to fight with PhRMA, and PhRMA got whatever they wanted. If I could just give you an example, which always galled me, under Medicaid, we wrote a law saying, since we're talking about the poorest of the poor, the pharmaceutical companies ought to give a discount for those drugs, what was called the best price. They would often give the best price because they wanted to get an HMO to start using their drug. And so we said, well, if you're going to give a best price to anybody, you ought to give a best price to the Medicaid and to the veterans. And they agreed to it. So when the Medicare Part D program was adopted, they took all the people that were dual eligibles. They were on Medicaid because they were poor, they were on Social Security because they were elderly and maybe even disabled, and said their drugs will be paid for under Medicare. And Medicare has been paying billions of dollars more for the same drugs for the same population that they were paying before under Medicaid. We tried to change that, and we weren't able to do it because PhRMA said they'll walk away from the whole Affordable Care Act, and we passed it through the House, but we couldn't get it into the final product. And President Obama's proposed it each year as a way to reduce spending, because we would in fact be paying a lower price as we were before the Medicare Part D. So it didn't really make sense, and it's just a huge loss of government funds.
You know, talking about politics, many of the people in our audience don't know about campaign contributions and have a different kind of political system, but the insurance industry is another one. There were certainly a number of people when the Affordable Care Act was being considered who believed in a single payer system of health insurance, who would have really liked to have Medicare for everyone. But yet we wound up going what I think of as a mixed private-public route, employer coverage for people who are working, Medicaid for very low-income people, state health insurance exchanges, marketplaces for modest-income people who maybe are self-employed or work for small businesses. So why wasn't single payer or Medicare for all a viable option?
I think it would be glib to say that these groups that become special interests and give campaign contributions and have power are the reason. But it would be unfair to what the reality was. We have a system that grew of employer-based coverage, and then to plug in the gap, we made sure that there was a Medicare system, and to take care of the low-income people, we adopted Medicaid, and that was the system we had. Now, if we were to go to a single-payer system, which I certainly would favor, we would have had to do dramatic changes that would have affected everybody, and that's not easy to do. Because not just the interest groups, because many of them were telling me, I'd rather have a single payer. Many doctors told me, ironically, they fought Medicare, but they said, I like Medicare. It's a much more reliable payer than when I go to private insurance companies who hassle me all the time and don't pay me the full amount and so on and so forth. So they said, let's go single payer. But I think President Obama wisely decided to make his proposal as modest as possible and leave most people with where they were. And even then, the Republicans and the opponents stirred up the pot so that people thought they were going to lose their Medicare, when of course they wouldn't. They were going to get a better Medicare. They thought they'd lose their insurance through their jobs. It didn't really affect it. In fact, it gave them a security that if they left their jobs and lost their insurance because it was tied to their job, they could do other things because insurance was still available to them to buy in the individual marketplace. So the basic premise of the Affordable Care Act was cover people who couldn't get insurance because they couldn't afford it by giving them a tax subsidy. And there are a large number of people who couldn't buy insurance on their own because they had pre-existing medical conditions, and so they were precluded by the insurance companies who didn't want to take that risk. They try to minimize their risk rather than spread the risk. And the idea of the Affordable Care Act was to spread the risk and cover that population, and then set in place changes that could affect the whole healthcare system, but not to do it all at once. Some people wanted a single payer plan. It would have been very, very disruptive. Some people bought into the idea of what was called the Wyden-Bennett plan. Take everybody and put them in a system where they didn't get the same tax breaks anymore, but the money that wasn't being used for tax breaks could help them with a defined subsidy, and then allow them to go out and buy a private insurance plan. And of course, people were already thinking about private insurance rather than public insurance, even though the most successful insurance plan that we have is Medicare, because the overall costs of Medicare, especially to manage it, a small percentage of what's being paid for when you have private insurance. We try to deal with the problems of private insurance charging too much for their overhead, for corporate jets and exceedingly high salaries to the CEOs, by saying that they could use no more than 15% for their overhead costs, and the rest of the money had to go to services for people.
Right.
And that we hope that will change things, and I think it is making a big difference. But Medicare is not 15%. It's, what is it?
I think it's about 2%.
You know, what a good deal it is.
So the government doesn't pay commissions, it doesn't
Right.
advertise. But I think you're right. I think seniors were stirred up when the
Yeah.
Affordable Care Act was considered, and there was a perception that their program, money for their program, was being used to pay for coverage of the uninsured. And yet we know that the Affordable Care Act added preventive services to Medicare without any cost sharing. It eliminated that donut hole in prescription drug coverage, and we now know it's extended the solvency of the Part A hospital trust fund by 13 years out to 2030, and it was projected to go bankrupt in 2017 when the Affordable Care Act was being considered. Do you think seniors today are still worried that the Affordable Care Act in some way is detracting from what they get out of Medicare?
I hope they're seeing that that's not the case. But we're talking about Medicare and Social Security being such a lifeline for people in their senior years. And they couldn't contemplate doing without, even though most of them don't live on, I think most of them don't live on Social Security, although a lot of seniors do, and it's a meager amount to live on. But Medicare is such an important part of what they need. So if somebody scares them and says it's going to be taken away from you, people get very excited. And of course, the story that's famous about this is that the opponents of the Affordable Care Act were saying this is socialized, government-run health care. And seniors would show up in the meetings and say, don't you get government involved in my health care. You leave it alone. I'm on Medicare. And they don't realize it is a government-run health care insurance system. They were stirred up, many of them. If you say the words Obamacare, they hate it. If you say Affordable Care Act, they like it better. If you tell them all the benefits that they're getting under Medicare, some of which you just mentioned, they say that's great. And if you tell them that people can get insurance without having to be precluded because of pre-existing conditions and other things like that, they like all the features, one by one, of the ACA. They may not like it if it's called Obamacare.
So one of the questions that has come in has to do with the different political perceptions of the Affordable Care Act and Medicare. The Affordable Care Act has been the cause of all these different political fights. Medicare has kind of been a little bit separate from that. In fact, you see bipartisan legislation to change how physicians are paid under Medicare go through. There are major changes in how Medicare pays for healthcare, major changes that are affecting healthcare systems across the country that have support from both Republicans and Democrats. So on the one hand, you have the most divisive period maybe in health policy in a while in terms of the fights over the Affordable Care Act and, Obamacare. At the same time, so much cooperation in a way, or support for changing healthcare to provide better value under Medicare. What do you think explains? Do you think everybody just spends all their, anger on the Affordable Care Act and then they can be a little more clear-headed about Medicare? Or what do you think's going on?
People would have been shocked if they had heard the debates that we had in our committees when we were considering the Affordable Care Act. And some of them talked about Medicare being one of the most unpopular programs around, how their constituents hated it. I just didn't know where in the world they came from when they would think that, because people all over this country, whatever regional differences there are, political points of view that might vary, they love their Medicare. They don't want their Medicare touched. But some of it had a history. There was a bipartisan effort at one time to balance the budget. And the budget during the Clinton years, the budget was moving in a way that was going to be balanced. But President Clinton wanted to do something on a bipartisan basis with Newt Gingrich and the Republicans, so they adopted a Balanced Budget Act. And the way they were going to balance the budget was to make cuts in physician payments in Medicare, always in the future, if the Medicare physician fees didn't just hold the line to inflation, which just doesn't happen that way because they work in a system where things cost more and more. And they threatened doctors with a drop in their fees. They took the extra money out of the Medicare program and provided for tax cuts. And that provided for the bipartisanship of the bill. I was one of the few that voted against it. Well, this SGR for paying doctors turned out to be a disaster. And at the end of every year, we faced a drop in physician fees under the law. So we would fix it. And what would we do to fix it? We'd say, well, we're not going to drop those fees for doctors. We're going to raise them a little bit, and that we usually paid for that by not paying for it, going into the deficit. So that was our problem, and we thought when we were doing the Affordable Care Act, everybody would agree to correct this anomaly, this stupid position that was written into law. Finally, that happened on a bipartisan basis at the beginning of this year,
Right.
wherein Nancy Pelosi and John Boehner, the Democratic and Republican leader, got together and said, let's correct this and not pay for it all. We tried to do it in the past. Oh no, it's got to be paid for. They decided they couldn't pay for it all, but they paid for most of it, and they extended the child health insurance program and the benefits for those at the community clinic level. So they had an extension of the money they were getting under the Affordable Care Act. It was bipartisan. Medicare is popular, and I don't think any Republican would say they want to get rid of Medicare. But boy, they opposed it when it was offered,
Yeah.
and they've opposed it in some of the expansions we would have liked, or tried to expand it in ways that took care of some of the special interests that they were most concerned about.
You know, obviously we have found savings by trimming what providers are paid. Sometimes it's not a cut, it's just slowing
Right.
the rate of
Right.
increase in their
Right.
payments. And providers are pretty effective at advocating their case
Yeah,
for
absolutely.
why they need the money. One of the provisions in the Affordable Care Act was called the Independent Payment Advisory Board. And the notion was to set up a group of 15 experts that would be independent, and you'd take provider payment out of the political process. They would make recommendations on how to change the way doctors and hospitals are paid, and that would go into effect unless Congress acted quickly to put something else in its place that would have the same effect on controlling Medicare outlays. Do you think it's basically a good idea to remove provider payment from the political process, or do you see problems with that?
You're never going to remove an issue like provider payments from the political process, unless you say to people you no longer have the right under the Constitution to make your case to your representatives, which is appropriate. And if the Medicare program is being changed in a way that hurts a provider to do the work that they think is in the best interest of their patients, because somebody thought of a great idea to save money, well, there ought to be a check on that, and Congress should be able to review it. We have MedPAC and other organizations we've set up to give us guidance, and more often than not, their recommendations are followed. But the IPAB was something the president wanted to show that he was doing everything he could to hold down healthcare costs, and it's in the law. It won't go into effect for quite a while. A lot of people have misgivings about it because it delegates authority to some board to make a decision that will stick unless Congress can come up with something else. And we don't know how that's going to work, but it shouldn't be thought of as taking politics out of it. Politics is not a bad word. Politics is a process where people get heard and raise concerns, and sometimes their concerns are very justified, and sometimes their concerns are just too much self-interested. Sometimes it's both, but oftentimes it's self-interest, and you have to say no. For example, there was a time that cataract surgery, when it was new, paid a separate fee for removing the cataract and then a different fee for putting the lens in to replace it. And the healthcare administrators said, of the Medicare program, said, that doesn't make sense. Why don't we just give one payment? And I remember hearing from ophthalmologists, that would be such a terrible thing to do for the patients. Well, it was a change in the technology, and that change and improvement justified a united, bundled, smaller fee than they were getting. So you need always that constant watching by both the people in charge of the program and their representatives to be sure that nobody's rights are being trampled on. It's a good check and balance.
Obviously, Medicare faces a lot of challenges going forward. After World War II, not surprisingly, there was a major increase in the number of babies born, and those are now starting to qualify for Medicare coverage starting in about 2011. And as that population ages, they have more and more chronic conditions. Sometimes they have strokes or Parkinson's or Alzheimer's that really undermine their ability to take care of themselves. And Medicare is not meeting all of the needs of people who have the most serious problems. They pay a lot out of pocket. The services aren't available. It's probably going to need to do more in the future. But also, as those boomers go on to Medicare, the federal budget's going to increase, and there's going to be more and more pressure to find ways of finding savings or cuts. How is Medicare going to be protected and be able to address the future needs of Medicare beneficiaries as the population ages?
It is a real serious challenge. Healthcare costs go up because of new technologies, new developments, and things that we never thought of 50 years ago and that we're now thankful that we have, but cost money. And so we need to be very careful to make sure that we're getting the most cost-effective program possible. So Medicare can look at a service and adjust the amount for a service, as I pointed out, on contact lenses or on cataracts. But we're also looking at systems and ways of reimbursing, not just for the quantity of care, because there's obviously an incentive to do more services if you can get more billings in and more payment, but to bundle the payments and provide some managed care, especially for people with chronic diseases. It doesn't make sense if you're on Medicare and you go to this doctor and that doctor and another. You need the whole system to be managed to deal with the chronic problems. They're not going away. It's not an episodic matter. It's something that people are going to have to live with, and we need to help them live with it. So we're trying to change the Medicare system to bring it up to date and to be more cost effective and to use the dollars wisely. But it is true that when we talk about cuts in Medicare, we're not talking ever about cutting from where we are. It's cuts for the projected increases in Medicare. And that's what we have to watch. How fast is this all going to grow? And when you get a baby boom generation, it's going to cost more. That's why in Social Security we had a prepayment for Social Security to pay more of the cost for the bulge population that was coming through it. And with Medicare, we have to try to make the system adapt to it and keep watching all the time to make sure that we're not being cheated by fraudulent actions by providers, that we're getting the best value for our dollars, that people are getting what they need. And that's why I think we have to go back and revisit some of the things we didn't do in the Affordable Care Act. We provided a catastrophic benefit for pharmaceutical companies. After they get through that donut hole, which we help them get through very quickly, then the pharma companies can charge whatever they want. The government's going to pay for it. Government's going to pay for it. It's a catastrophic coverage. And I think there are a lot of places where we pay too much and we ought to revisit it. We have to always be balanced because we don't want to cut payments to manufacturers of drugs when they produce new cures for these diseases, new possible cures for Alzheimer's and other dreaded diseases that are chronic in nature and they're very costly to treat. For example, obviously this drug for hepatitis C, very, very expensive drug, but it was a drug that cured the disease.
Right.
Not just a drug that dealt with the symptoms. So I think we have to be a little bit more sophisticated in figuring out how to deal with the increasing costs of drugs, which is the fastest growing part of our services for Medicare and other insurance, but then also to bring the system into a more coherent balance that provides the beneficiary with the best quality at the most cost-effective way.
Well, I think Medicare is maybe the last of the great social insurance
Yeah.
programs, and its principles are it covers everybody, healthy or sick. It covers everybody, rich or poor. It finances it largely with taxes that are based on people's ability to pay. But yes, we hear a lot of proposals that we ought to just give people the money and let them buy
Yeah.
private insurance on their own, which obviously is a good deal maybe for healthy or well-to-do people, but not such a good deal for people who are sick or living on the margin as many Medicare beneficiaries. What do you see the threats to Medicare being going forward?
Well, those kinds of theories are the threats that we have to be very worried about. The Republican-controlled Congress adopted a budget where they want to take Medicare and make it into a voucher system so that everybody will get a certain amount of money, go buy a private insurance policy, not have Medicare anymore. Maybe they had something where you can buy Medicare for a while. But their goal is to have a premium support system. You support their premium and then tell them you want better, go out and put in more money and buy better. And that may not be troublesome to people who have the wherewithal to put in extra money, but there is this image that I think is mistaken that all seniors are wealthy. A lot of seniors cannot afford to put in more for health insurance, and they'll be stuck with the poor people's health insurance program under Medicare. And one of the great things about Social Security and Medicare is everybody benefits the same. And it's an equalizing program, and we don't means test it so that people say we want to do more for the poor. They're faster to cut a program for the poor people than they are for the middle class. So we've got to keep Medicare an entitlement for everybody to be treated the same. What we've done instead is to charge people who have more income a higher premium. So in effect, we're saying they can afford to pay more. They should pay more for their premium, not to take less in their services. And that is okay. I've supported it. But you have to be mindful that if you make the premium too expensive for people who are healthy, maybe elderly, but they're healthy and they can afford it, they'll go out of the system and buy private insurance. And then Medicare will be left with people with less money and more costly expenses for their health care. So you have to do the things in balance if we want to make it more equitable to say, if you're rich, who would they say? They would say, who's the richest person around? They used to say Rockefeller, but then that got too close to the senator. But but if you're super rich, people say, why should we do this for Gates? He could afford everything on his own. Well, yes, he could. On the other hand, they're taking a very small example and overgeneralizing it, and there are a lot of people who can get hurt if you don't handle it wisely.
Great. So we have a question that's come in through email. publichealthpractice@jhu.edu if you have questions. Question is, could you imagine as you talked about Part A, Part B, the prescription drug coverage are all separate parts of Medicare, and that inhibits information from flowing back and forth. It makes it harder to manage the program. Some people forget to sign up for different parts. Can you imagine those parts coming together more? They come together when people sign up for managed care. I know, Professor Davis, you proposed some changes to Medicare. Is that something that, and maybe Professor Davis, you may want to comment on this first, and then Congressman Waxman, do you imagine that that's a direction that Medicare can go? I mean, there was a reason to start with a part for hospitals and a part for doctors and a part for drugs, but healthcare has really shifted away from that really to be more patient-focused, and it's just a question about whether those kinds of changes might happen.
Well, I think breaking coverage up into different parts, a Part A for hospital, a Part B for physicians, a Part D for prescription drugs, and then such high deductibles and out-of-pocket that people have to buy supplementary private Medigap insurance to go with Medicare. It's confusing to older people. It's administratively expensive. As Congressman mentioned, there's a high overhead on this supplemental Medigap coverage, actually around 20%, whereas Medicare's administrative costs are 2%. And it's hard to coordinate care or to move people out of hospitals that may wind up costing more for physician services or for prescription drugs when they're all financed differently. So I think if we were to start fresh, we would design Medicare this way, and employers don't provide coverage that way. They provide a comprehensive package of benefits to their employees. Certainly the better firms, the good jobs, the larger firms, it's a comprehensive set of benefits all under one umbrella. So definitely I think that has a lot of merit. But the question, I guess, to you, Congressman, is what's the prospect of changing Medicare to really integrate the different parts and bring them together, put a ceiling on the maximum amount that anybody would have to pay, maybe making sure that modest income beneficiaries have premium subsidies the way we do under the Affordable Care Act, because Part B is now costing $100 a month. That's $1,200 a year for an elderly person with an income maybe just living off their Social Security check. That's a lot to pay.
One of the exciting things that I have found being here at Johns Hopkins is the opportunity to get many of the ideas that academics have been thinking about on how to improve our healthcare system. And sometimes you get these great ideas and it's not converted into policy when it should be taken up. I would guess the reason that we've had these divisions between the A, B, C, and D, and because it's historical. And then once it's there, people have a vested interest in keeping it there, sometimes for committee jurisdiction. Because I know in the House, if it's Medicare Part A, it goes to the Ways and Means Committee, but if it's the rest, it's shared with the Energy and Commerce Committee. And some of it even may get a review by the Education and the Workforce. So you got, but that should be a reason not to make some of these changes. People don't think about their coverage in those categories, so I think it would make a lot more sense and probably pull together the system and make it more coherent. And then I think there's some exciting things that are being talked about here on campus about how to do more for the long-term care piece, that chronic care that is no longer just a medical problem, but Medicare doesn't pay for it. As we mentioned, if you had to go to a nursing home, it would be a couple months at most after a hospitalization that Medicare would pay. But if you needed more care beyond that, or care at home or in a different setting that would be more realistic and even more cost effective, we ought to figure out some way to expand Medicare to cover it. And we could hold down the costs and we could better serve the needs of the elderly. But there's always a resistance to change for lots of different reasons. Sometimes it's because it costs more, but even when it doesn't cost more, you have people say, well, this is the way we've always had it. We're celebrating 50 years of Medicare. We're also celebrating 50 years of A being separate from B, and then later C and D added on and being separate from A and B. And Medicaid is a completely different system run in a very different way.
Oh, go ahead.
And you mentioned particularly that Medicare doesn't help people live independently at home. I think it's not just the fact that Medicare covers skilled nursing facilities for maybe 30 days after you come out of a hospital, but they don't really provide the services in the home if you need an aide to help you feed you or bathe you, or if you have problems walking or getting in and out of bed and need some kind of personal care. And it doesn't really support families that try to help out by, say, making senior day centers available so families that are working can take care of older parents in the evening, but have some alternatives during the day. I don't think people realize that you have to be poor or you have to have all of your savings wiped out to get those kinds of services from the Medicaid program, and they're not covered by Medicare.
It's tragic and inhumane to do that to people, especially when they're quite desperate and in a much more circumscribed living situation. And it's almost the way we thought that mental health was something completely different from physical health. And we said, oh, we're going to take care of your physical health, but we're not going to take care of your mental health. It's only recently that we adopted what's called mental health parity.
Right.
It shouldn't be these separations of healthcare services, and it shouldn't be a separation of what's called treatment from what is important to the quality of life for patients, which of course affects their medical condition and their psychological sense of well-being. So I think we've got to look to fill this in and to move forward in this direction.
And one last question, which is maybe a little bit of a brighter note, which is that the Medicare program has a tremendous history of experimentation, demonstrations, creativity. The Innovation Center at CMS now is leading some changes that have gotten not just national attention, but global attention for thinking about healthcare costs differently, from accountable care organizations to what we have here in Maryland, which is the nation's only rate-setting system for hospitals, including really leaving behind fee-for-service hospital payment for Maryland residents. How is it that you have a program that has been so helpful to older Americans, is so popular, and yet you see all this creative exploration, and as this conversation has illustrated, it's kind of changed in all these different ways? You know, there's not just support for the program, but there's support for different kinds of demonstrations and models, and there are models now where states can pool their Medicare and Medicaid funding to do better for seniors who are eligible for both programs. So, you know, any insights that you have about, you know, Medicare not really being a static program and having support maybe from Congress and others to constantly improve in these ways looking forward?
I think it's a very much of a changing program. It's changed dramatically over the years. There are strong improvements that are taking place with new ideas and new concepts being experimented and demonstration projects to learn from it. And I don't know why other states haven't learned from the Maryland experimentation of bringing all the hospitals together and working on a system to pay them, whoever the payer is, in a uniform in coherent way. It's hard to do some of those things, but some of us worry about what may be coming around the bend. If we had the Paul Ryan proposal, which is part of the budget, adopted by a majority of the House and Senate, implemented, Medicare would be radically changed. Medicaid would be more dramatically changed, because they want to have the government say, here, states, here's some money, do the best you can, you don't have to do much of anything. We shouldn't take for granted what we have. It shouldn't keep us, on the other hand, from trying to improve it. But we ought to recognize that there are people who don't believe that it should be done. They usually have an economic model that makes people the purchasers and the consumers, and therefore wise economic players in a world where there's always somebody who's willing to take advantage of money that may be available to them, for money that may be available to them, either out of the pocket of the senior or other patient, or out of the payers for them. So I think we have to be alert that Medicare is a great success. Medicaid is a better success than anybody ever envisioned, and we've got a system that may not be the ideal system, but we've got to keep building on it and not go backwards. And there are people who would take us backwards.
That's great. Well, this has been such a fabulous discussion, Medicare at 50, part of a day where you'll be talking to students and faculty here, hearing about research projects, talking to community members about Medicare. We really appreciate it. I want to give each of you maybe a chance for a closing comment before we wrap up this particular webcast. Professor Davis?
Well, I think we have learned that Medicare has been a success, and it's made an enormous difference in the lives of elderly and disabled beneficiaries over the last 50 years, getting them protection against the cost of medical care and making sure they get great medical care. But we've also learned that Medicare has been a leader in innovation. Medicare today is not the same program it was 50 years ago. It's not your grandmother's Medicare program. It's, as Congressman Waxman has indicated, it's covered, for example, cataracts on an ambulatory surgical basis, and now lots of surgery is done on an ambulatory or outpatient basis. It covered hospice services when that service became available. It's changed the way it paid. It started out paying hospitals' costs and physicians whatever they charged, the way private insurance did. But it's really been a leader in developing better ways that really reward getting better outcomes for patients, better care experiences, lower costs, called paying for value. And with the Affordable Care Act, we're now investing $10 billion over 10 years in the Center for Medicare and Medicaid Innovation to make sure it continues to lead in providing better ways of providing better care more efficiently for our nation's seniors and disabled. But those advances are also picked up by private insurers. They're picked up by countries around the world. Over 40 different countries now pay hospitals using the Medicare payment method. So yes, Medicare faces a lot of challenges moving forward, but I think this record of innovation and change gives us some comfort that Medicare will rise to the occasion in the future.
Congressman?
Well, I agree with everything you said, but not only will Medicare continue to play this role of innovation and developing more efficient ways to provide care using new technologies, new systems, but which will continue to benefit the people that are eligible for it. They're entitled to it. But it's going to benefit all of us because our healthcare system is going to learn from successes and failures in Medicare. Medicare's become the teacher for private insurance when they try to figure out how to make their systems better. It's going to be the way that the individual policies are going to have to emulate what Medicare has done. And Medicare preceded the Affordable Care Act in saying all insurance ought to be based on certain set of benefits, not go buy a cancer policy or buy something else. In fact, at one time, people bought supplemental policies from Medicare that didn't really provide much for them, but they thought they were getting protection. We're regulating insurance to make sure that when you buy it, you're getting what you bargained for, and you're paying a decent price for it. And we've got to keep Medicare as that linchpin, that social insurance system that, along with Social Security, has been the two great successes, and Medicaid as well, of making sure that everybody in this country is treated fairly and that we're trying to all be together and advancing forward, not leaving people behind.
Terrific. Well, I would like to thank you both for participating. The Centennial Policy Seminar Series is made possible in part through a generous gift from an alumna of this school, Frances Henkel, who received her doctoral degree from the Department of Health Policy and Management in 1985. We're grateful to Frances for helping to support this important program. And the other series that will be coming up, the panel at noon, as well as on the other days, we'll be talking about such issues as HIV, tobacco, long-term care, and others in the spring. So this is a great start to your time at the school, and thanks so much.
Thank you.